Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Markus Peck-Radosavljevic, Professor of Medicine from the Medical University of Vienna in Austria, and Dr. Josep Llovet, Professor of Medicine from the Mount Sinai School of Medicine in New York. They will be discussing current first-line treatment options for advanced hepatocellular carcinoma, including the role that tyrosine kinase inhibitors now play with the combination of Atezolizumab and bevacizumab as the standard of care, as well as ongoing clinical trials in this disease setting. This episode is part of a larger educational program titled Current Topics in Oncology, a focus on tyrosine kinase inhibitors in solid tumors. For more information on the experts, along with a link to the complete program, including a downloadable slide set covering the topics discussed in this podcast, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
A lot of things have happened in first-line treatment in HCC. What is your take on what we should do at the moment?
Well, certainly the last 3 years have been very exciting, I have to say. We had a lot of news. We have now a new treatment paradigm with reporting of the trial of Atezolizumab plus bevacizumab in frontline. This trial, in my mind, of course, opens a new era of management of patients with advanced HCC with combinations. And we need to also figure out which patients should be treated with this combination and which patients should be still treated with sorafenib and lenvatinib. So my take is that overall, the standard of care by default is the combination of Atezolizumab, maybe implemented in 80, 70, 90% of the patients. It is not known nowadays because there is no actual report of real-world use of this combination. But I would say that the combination has a very good results in terms of overall survival, 19.2-month median overall survivals, and very good safety profile. So the question on which are the main contraindications, right? Certainly one of the contraindications that is critical is that it cannot be given in patients undergoing liver transplantation or that already are transplanted. Secondly, in patients with any contraindication for checkpoint inhibitors. And then there was the issue of the endoscopy. As you know, in the trial, they requested an endoscopy 6 months prior to the start of the therapy to discard high-risk varices, and in that case should be treated. So if the varices are still there or are untreated or there is a risk as a result of bevacizumab, then I would say that still sorafenib and lenvatinib are frontline. So the question that eventually we can discuss is how do you sense the use at this point already in your place? Secondly, how do you analyze the adverse events of the TKIs in frontline compared with the combo? So what's your take?
We also implemented the same first-line treatment in our institution, but I would say 70% maybe of the patients are really suitable for that in our institution. I mean, just today we had a patient that really had other comorbidities. For example, his heart was not in very good shape. He had cardiac ischemia. So he was not really a candidate for combination drug treatment. And this patient, we will start on a TKI, for example, in first-line treatment, and not give him a strong anti-angiogenic like bevacizumab or even an IO agent in this case. Yeah. So we look at it basically the same way you look at it. Transplant patients, we will not give an IO agent at the moment because we still don't think it's safe to do that. And autoimmune diseases is another area where we tend to shy away from IO agents and tend to go with a TKI in first line still.
So one of the concepts that I think that these TKIs that were, first of all, sorafenib in frontline as a standalone, then it came Lemba with a non-inferiority. And now after Atezolizumab, it's not that they are completely out of the picture. They are in the picture completely in frontline in 20-30% of the patients. But eventually, nowadays, according even the guidelines, they will be the first option as a second line. And I think that this is important because these are effective drugs. Sorafenib have been huge experience throughout 12 years in the use of this drug. And nowadays the reported treatment-related adverse events leading to discontinuation are very low, and leading to decrease of those are being optimized lately. And Lemba also has outstanding results in objective response and is very well also implemented in most of the centers. So I would say that the role of these two agents is not only in frontline, but also even in considering progression to Atezolizumab. So I have another question, because there is the issue of what's going to happen with the new release of information, right? So we have the Himalaya, that is durvalumab plus tremelimumab, that hit the endpoint of OS, and at the final analysis it was positive. We don't know the details of the results, but this may be another important piece of information in the decision making in frontline. I would say that the IO-IO combination, so we're talking here about anti-PD-1, anti-CTLA-4, it's producing a profound impact in those patients achieving response. So they achieve long-lasting responses, and you have a lot of patients at 2-3 years alive and with good response. Conversely, considering the overall target population, whereas Atezolizumab achieved disease control rate in 70% of the patients, and even other combinations I recall Lemba Pembro even in 90% of the patients, disease control rate. These IO-IO combinations, the disease control rate is 50%. So they really create an impact in a narrow population, but in this population is more profound. Let's see the final results, but I think that this combination may be also something to be taken into account. The same is the interim analysis of the Cosmic 312 with Atezolizumab. They hit the co-primary of progression-free with a hazard ratio 0.63, but not there the overall survival. So now imagine the situation in which all these drugs are available, these combinations. So where do you think still the TKIs may have a place there? Certainly, I would say that the contraindications of immune-related adverse events associated to patients with autoimmune disease or liver transplant will remain, because all these combinations include checkpoint inhibitors, right? So I think that this percentage might not change so much, because in terms of the other 70%, eventually the decision-making will be, okay, are we using Atezolizumab or are we using Durva-Treme, or eventually Lemba Pembro, imagine the LEAP-002 is positive, or Atezolizumab. But still, there will be a percentage of patients in frontline that cannot be exposed to immunotherapy. What do you think about that?
I think also, looking at especially the Child-Pugh patients, I mean, some people don't treat them because in most trials they were excluded. However, the reality is that especially the good Child-Pugh, the non-decompensated Child-Pugh patients oftentimes get treatment. And in those patients, especially if you have portal hypertension and so on, then probably the TKIs still play a relevant role, in particular when you're looking at Atezolizumab as the alternative option. I mean, the game will be changing when you have IO-IO agents, because then you're probably not worried about bleeding that much any longer and about portal hypertension. And that might be an option as well. However, I mean, IO-IO agents, I completely agree with your estimation, but Immunologic toxicities are a bigger issue in these. So we really, I will be very keen to see the data. And I mean, yes. Himalaya, the interesting thing was, of course, it was still run against sorafenib, right? So it had a fairly easy comparator, to put it that way.
Well, I mean, in terms of what you were saying, the adverse events, I know the data of the phase 2 of Nivo-Ipi, because as we know, this combination is approved by FDA in second line. And in 50% of the patients, they require corticosteroids to manage adverse events. So let's see the data also of the Himalaya trial and to provide additional information to this. So I would say I would conclude this section stating that first, the frontline standard of care is Atezolizumab, has represented a breakthrough in the management of advanced HCC and also in intermediate patients progressing to PACE. This standard of care is applied to, let's say, 70-80% of the population in frontline. If we're talking about mostly Child-Pugh A-class patients, that a percentage of patients cannot be exposed to this combination, mostly because they have autoimmune disease or any contraindication for checkpoint inhibitors, or because they have been transplanted and there is a risk of graft rejection, right? And these patients should be exposed in frontline to sorafenib or to lenvatinib. Second issue will be upon progression, but also these two agents may have a clear role. And the third would be, okay, now we know at least two trials. One is the Himalaya that hit superiority, Durva-Treme, and this will also become the standard of care. We need to see the actual data in order to understand exactly the magnitude of the benefit and the strength of the evidence. And the second thing is the Cabo-Atezo hit the interim for progression-free, but we're waiting for the overall survival. Well, also we have LEAP-002 that show very exciting phase 2 data with Lemba-Pembro. Let's see what happens. And this will also complicate the management, but also provide good tools for the patients and for the physicians. So with this, I think that we can conclude the analysis of the first-line systemic therapies for HCC.
Thank you very much, Dr. Peck-Radosavljevic and Dr. Llovet, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Current Topics in Oncology, a focus on tyrosine kinase inhibitors in solid tumors, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.